It's Conduit News Radio with Paul Harrell.
So there is an op-ed that was written December 31st by Dr. David Mitchell, and it is entitled Better Healthcare, Empowered Nurse Practitioners. It's really, really good because this is talking about allowing people to practice in their full scope of practice. And David Mitchell joins us on the phone right now from the Arkansas Center for Research and Economics. David, welcome, sir.
Hi, how are you?
I am doing.
Thanks for having me on.
Yes, sir. I am doing.
I'm excited to be on Johnny Cash Friday.
Absolutely, yeah. It's one of the best days of the week for sure because he's an Arkansas legend, an Arkansas tradition. So, so I read your op-ed. So just tell us what's this all about?
So one of the things that happens in Arkansas is we have a really serious access to care problem. So what that means is we're 46th in the country for physicians per capita. So we don't have very many physicians for the number of people we have. And this hits rural areas especially hard. So I live in Little Rock. I actually walked past one doctor's office on the way to my doctor's office. But because we don't have very many physicians and they tend not to want to live in rural areas, if you live in a rural area or you live in some other underserved area, there's just not enough physicians to go around. There's not enough healthcare providers. That means wait longer, you drive farther, you're more likely to put it off, you're not getting the care you want. So that's what that means, that we have this access to care problem.
Okay, 46.
And when I talk about primary, go ahead. I'm sorry, go ahead.
No, I'm saying 46 in the country. That's not
46.
Good. Yeah.
Wouldn't you like to be, man, I want to just be in the top half. I hate to say this, I'm glad we're not 49th. I get tired of being 49th.
Yeah.
But, sometimes I feel like we're the real 49ers, not San Francisco. But wouldn't you like, I want to first be in the top half, and now I want to start being in the top 10. Wouldn't it be great to be in the top 10 for something good, not for something bad? I want to be in the top 10 for something good.
No, I totally want to be in the top 10.
My goal is because that would mean that our lives are better, not because we'd be better on some list.
Yeah, no, I agree. So what can we do, Dr. Mitchell?
So let me tell you what primary care is first, and then I'll tell you what one of the things we could do. So primary care is that first connection between a patient and the healthcare system. That's where you get your first diagnosis, and you manage your stuff, and you get preventative care, and it could be things like long-term stuff, diabetes. It could be short-lived things like a sinus infection. It's everything in between. So one of the things that we could do is we could have more nurse practitioners, and we could have nurse practitioners do what they have been trained to do. We could let them really do what they've been trained to do. Part of the dilemma is that fewer medical doctors want to do primary care. It doesn't pay as well as being a specialist, and I understand how incentives work. I'm an economist. So if one thing pays really well and the other one only pays okay, people pick the thing that pays really well. But nurse practitioners, they don't have that option. They focus on primary care. And there's actually an article that came out last week saying that nurse practitioners are much more likely to practice in underserved and rural areas. The problem is that Arkansas limits these nurse practitioners.
So what does that mean? Arkansas limits nurse practitioners. Practically, what does that mean?
Well, we have these rules, and these set of rules are called scope of practice. So it sounds kind of complicated, but scope of practice just means that what are the rules for what the different medical professions can do? Who's allowed to do what? Some of it makes total sense, right? A whole bunch of people are not allowed to do heart surgery. Only surgeons are allowed to do heart surgery. Right? There's a whole bunch of things that make sense. But there's a whole bunch of rules that have been written perhaps because people didn't know how good nurse practitioners are, perhaps because people were afraid of the competition. That's the dilemma with these safety rules. That safety rules always sound good, but sometimes they're really about limiting competition. So we have these set of rules on scope of practice, and they limit to three things for nurse practitioners. One of them is prescriptive authority. So that just means that nurse practitioners can't prescribe the full range of drugs. You might have a severe case of diabetes, and you have all these painful things that come from it. You might have diabetic nephropathy, and all these other things that you try not to think about. Nurse practitioner can't help you with that part.
Mm-hmm.
Second thing is physician supervision. Nurse practitioners, if they want to practice on their own, have to have a collaborative practice agreement. Collaborative practice agreement, you're like, oh, okay, the doctor who has more training helps. That's probably a good idea, you might think. But really, it's a way for the nurse practitioner to pay thousands and thousands of dollars every year to some physician to oversee their work. They don't oversee your work the way you think they do. You're sort of imagining that they're walking side by side down the hallway and looking over things. No, it's at the end of the quarter, physician magically picks up a couple of charts and says, oh, yeah, that sounds good. Where's my check?
Yep.
Since it's not very good supervision, it's not what people might imagine, it's just an extra cost. It's just an extra cost.
Well, so
and go ahead.
No, well, I mean, that's not. Yeah, I mean, I think you're exactly right there. Because I've heard that from others before, as well as people who are very familiar with what's going on in the medical community with, physicians and nurse practitioners. We're talking with Dr. David Mitchell, director of the Arkansas Center for Research and Economics. Now, you said that one of the things that they limit is prescription writing, the full scope of what they can write. So let me ask you this, and I'm just trying to play devil's advocate here.
That's
because
okay.
I know, like you said, if the rules are not really about safety, there will be people that make contrived arguments to make it look like it's really about safety, but it may just really be about money. So what about the opioid crisis? Would getting rid of that rule, could it potentially make the opioid crisis worse?
No, I don't believe that for a second. So, 2 years ago, Arkansas passed a prescription monitoring program for control of substances that every time any kind of provider writes a prescription for any controlled substance, it goes to the database, and they can look for alerts, and they can sort of see what's going on and who are the providers that are providing lots of stuff. But also, that rule, I mean, it feels a little bit of like an invasion of privacy because it feels like, oh, now the state knows that I have a prescription for something. But that rule is designed partly to make sure that there's no providers that are writing lots of prescriptions, that you're not having one doctor writing stuff like it's candy, but also it helps find patients who are shopping who have 5 different physicians writing them prescriptions. So we have that program in state. I don't worry about it too much. The most important thing is when they've done some research on which of the states that have the most pain prescriptions per 100 people, the states that are the worst are Mississippi, West Virginia, Louisiana, Arkansas, and Michigan. Hey, those 5 states really control what nurse practitioners do and don't let them have full prescriptive authority. Then they looked at the states with the lowest amount of pain pill prescriptions. They were states like Nevada, Idaho, Oregon, Connecticut, Hawaii, Minnesota. Hey, those are the states that let nurse practitioners, do the full, to practice full extent of their authority. So you think, wait, the states that let nurse practitioners do the most are the states that have the least problem, and the states that let the nurse practitioners do the least are the states that have the most problem. It's not nurse practitioners causing the problem.
Wow.
If nurse practitioners are causing the problem, we have to work on nurse practitioners because that's a serious issue.
Wow. Okay. Another argument, and I'm just playing devil's advocate. So
no, it's okay.
Yeah, I think this is good though because I actually am against not allowing people to practice the full scope of their training in practice. But people may say, okay, well, nurse practitioners have less education than doctors. Do they provide good care? Do they provide the same level of care?
So first of all, most people don't actually know what a nurse practitioner is. A nurse practitioner is a registered nurse who went and got a graduate degree in nursing. That includes advanced coursework and lots of clinical hours. Clinical hours is just a way of saying they got lots of practice doing it. They did a lot of learning on the job with the supervisor, walking around, learning how to do the job. The training does not take as long as an MD's training. But here's the thing. Don't confuse inputs and outputs. Years of training is an input. But what we care about is how well the patients are treated. I don't care how long it took you to learn something. What I care is, did you learn it so that you can help people? So there's a tremendous number of studies showing that NPs, that's a nurse practitioner, provide equal or better primary care than MDs. So part of the reason they provide really good care is they have great training. Part of it is they're much more likely to listen. So if you think, one of the things that's really interesting is that the average visit with a physician is about 7 minutes. Average visit with a nurse practitioner is about 12 minutes. You think, wow, 7 minutes to 12 minutes, that's almost double. That's a huge increase. That additional listening and talking to you, and also saying things like, hey, how come you're not taking your medicine regularly? That's really valuable. That's one of the things that kind of separates them out a little bit. But the thing that's in my mind really interesting is that they've done these randomized control studies. And those are the studies where patients come in, they randomly get assigned to either a physician or an NP. Results are the same. The outcomes are the same. So you think, wow, okay, the outcomes are the same. This is for primary care, right? Because nurse practitioners don't practice oncology. This is for primary care. If outcomes are the same, then faster training is a feature. Faster training is not a bug. It's a feature. Oh, I can have a primary care provider, and I can get them quicker? I don't know why I don't want that.
Yeah.
Why wouldn't I want a really good primary care provider who also comes quicker?
So it sounds to me like if Arkansas is 46 in the country, David, when it comes to physicians per capita, and we have this nurse practitioner option, but they can't practice right now within their full scope, but they're also spending more time with patients, that sounds like that might put a dent in where we are on that list. So how do we get more nurse practitioners?
Paul, you're exactly right. It does put a dent in the number of nurse practitioners that want to work in our state. So nurse practitioners, there's good evidence that you get more nurse practitioners when you let them do the full scope of their work. And there's two reasons. One, if they get to do the full scope of their work, and they don't have to pay thousands of doctors to some collaborating physician, then they're more likely to want to come. They're going to make more money. So that's the external, which you might think of like the external motivation. Oh, okay, I make more money in states where I get to, practice to the full scope of my training. There's also an internal motivation. That's this idea that people want to practice in a place where they get to be the decision maker, where they get to say, I went to graduate school in nursing, I've learned this much stuff, and I get to be in charge of my own life. As weird as it, people like to be in charge of their own lives, not just in nursing and in jobs, but across the board. So when you have a full scope of practice, when you let nurse practitioners do their work to the full extent of their training, they want to come to your state. People who are currently registered nurses, they want to become nurse practitioners.
Yeah.
This is a problem that actually takes care of itself. It's one of the things you're like, oh, if we got out of the way, it's not a silver bullet, but we'd have more nurse practitioners, we'd have better primary care. Wow, that would be great. But we got to get out of the way. That's the problem. We haven't gotten out of the way.
So are there more people that recommend this increase of nurse practitioners than just, Acre?
Just me?
Yeah, just you.
There's more than just me. Yeah, absolutely. In fact, it's pretty weird. It's pretty bipartisan. So research from the Trump administration and the Obama administration both recommend the increased use of nurse practitioners. Think tanks on the right, think tanks on the left. Federal Trade Commission, National Academy of Medicine, which is formerly called the Institute of Medicine, National Governors Association. It's actually pretty broad. There's really only one group that really doesn't like nurse practitioners, practicing to the full extent of their training.
Wow. Okay, so let's talk about saving taxpayer money. I mean, is that a thing as well with reimbursements? Right.
So in healthcare, when providers get paid, they call it getting reimbursed. I don't know why they don't just call it getting paid, but they call it reimbursed. And NPs bill at 85% of what MDs bill. So that 15%, that can add up really quickly. And that 15% is set by the Centers for Medicaid and Medicare Services. So it's not something that NPs could negotiate later on. It's set by this CMS. So one thing that we did here at Acre is 2 years ago, we looked at the way that the NPs could save the state money. And we figured out that if only a few people on Medicaid, so Medicaid is for poor people, Though a lot of people in Arkansas are on Medicaid or ARC kids. Medicare is for elderly people. Sometimes people flip those around. So if people switched on Medicaid, only a few of them switched for only a few of the most common things, we'd save about $575,000 per year. If more people switched, and they did it for most of their stuff, then the state could save $1.7 million. But it's $1.7 million per year.
Mm-hmm.
Well, think, what could we do with $1.7 million per year? You could give the money back to the taxpayers. That's one thing you could do. That's what I'd like to see it done with. But you think, wow, $1.7 million, that's a lot of police officers. That's a lot of school teachers. It's not very much roads in Arkansas for some reason.
Yeah.
But, $1.7 million. Even if you say, Mitch, I don't believe it's full 1.7. Take half that.
Yeah.
That's a yearly amount just for Medicaid. Wow, that's a huge savings.
Yeah, that's
remember,
really good.
Medicaid is about a fifth of the state budget. So if you took some of that money out of that, you're on your way. And we just said, what if people just switched? We didn't say, hey, if people get primary care, they're less likely to go to the emergency room. We didn't say, hey, you get real savings from early detection and management of diseases. We just looked at what if people went in for their regular visit, and instead of seeing a physician, they saw a nurse practitioner. And we know that physicians often don't really like to see people on Medicaid anyway because the rate's not as high as some other things.
Right.
But we looked at the real numbers from the state of Arkansas and what would happen. What would happen if 10% of these people switched over? What happened if 20% of them? What if they did just a few things? What if they did 10 things?
And that number can change. We're talking with Dr. David Mitchell. He's the director of the Arkansas Center for Research and Economics, and he's really got a great idea here. And David, this is really about choice. This is about freedom of choice. This is about giving the consumer, which we don't ever talk about in healthcare, a choice. In order to do that, you got to let nurse practitioners do what they were trained to do fully.
That's right.
So go ahead. We're running out of time here, but go ahead and tell us, remind our audience what the Arkansas Center for Research and Economics is all about.
Yeah, so ACRE is a university-based research center. We're housed at the UCA College of Business, and our research focuses exclusively on Arkansas. So we only do state-based things. And our main issues are labor market regulations, including things like scope of practice rules for nurse practitioners, taxes and spending, and transparency. And we feel like those are three big issues that could be worked on in Arkansas that would make a real change in people's lives.
Real quick, are there plans to try to tackle this nurse practitioner issue in the upcoming session that begins on Monday?
So 6 years ago, people were working on it. 4 years ago, people were working on it. I know there's a couple of people working on it this current session. At the very least, we could let people in Medicaid go to nurse practitioners as their designated provider. That would be a really small change, but that would save money for the state, and it would give people more choice. And I think more choice is better.
Absolutely. Dr. David Mitchell, it's always great to have you guys on. I really appreciate the fine work that y'all do.
Thank you very much. I appreciate it. Don't forget, nurse practitioners provide excellent primary care.
All right. Dr. David Mitchell, appreciate it. The director of the Arkansas Center for Research and Economics. Check them out, ladies and gentlemen. They've got some great research papers. Always great to have. Anybody from ACRE is always fantastic to have on the program.